Welcome to Unit 9, Cardiac, Oxygenation, Fluid, and Electrolyte Management. In this unit, we'll focus on acid-base interpretation, shock and dehydration, renal regulation, electrolyte imbalances, and IV therapy safety. These topics require step-by-step clinical reasoning and careful prioritization. Let's begin. Now let's review acid-base balance basics and A, B, G interpretation. These are the foundational normal values for arterial blood gases. The normal pH is 7.35 to 7.45. If the pH is below 7.35, that indicates acidosis. If it's above 7.45, that indicates alkalosis. The normal PaCO2 is 35 to 45 millimeters of mercury. This represents the respiratory acid component. The normal bicarbonate, or HCO3-, is 22 to 26 milliequivalents per liter. This represents the metabolic base component. When interpreting ABGs, always go step by step. First, look at the pH. Second, evaluate the CO2. Third, evaluate the bicarbonate. Then determine whether compensation is occurring. A helpful way to quickly identify the primary disorder is the Rome method. Respiratory opposite. The pH and PaCO2 move in opposite directions. For example, if the pH is low and CO2 is high, that's respiratory acidosis. Metabolic equal, the pH and bicarbonate move in the same direction. If the pH is low and bicarbonate is low, that's metabolic acidosis. Now let's talk about compensation. Uncompensated means the pH is outside the normal range and only one system is abnormal. Partially compensated means the pH is still abnormal, but both systems are involved. The opposite system is trying to correct it. Fully compensated means the pH has returned to normal, but both CO2 and bicarbonate are abnormal. Here's how the body compensates. In respiratory acidosis, where CO2 is high, the kidneys retain bicarbonate to raise the pH. In respiratory alkalosis, where CO2 is low, the kidneys excrete bicarbonate. In metabolic acidosis, where bicarbonate is low, the lungs compensate by blowing off CO2 through hyperventilation. In metabolic alkalosis, where bicarbonate is high, the lungs retain CO2 through hypoventilation. In summary, always start with the pH, determine whether the primary issue is respiratory or metabolic, and then assess whether compensation is occurring.
Now let's clearly compare respiratory and metabolic disorders. First, respiratory alkalosis. The ABG pattern shows high pH and low PaCO2, with bicarbonate normal early on. The cause is hyperventilation. Clinically, this may occur with anxiety, pain, or mechanical overventilation. Next, metabolic alkalosis. The ABG pattern shows high pH and high bicarbonate, with PaCO2 normal early. Common causes include vomiting or NG suction, which lead to hydrogen ion loss. Patients may present with weakness, hypokalemia, and muscle cramps. Now, respiratory acidosis. This shows low pH and high PaCO2, with bicarbonate normal early. The cause is hypoventilation. Common clinical situations include COPD exacerbation, pneumonia, or opioid overdose. Finally, metabolic acidosis. This shows low pH and low bicarbonate, with PaCO2 normal early. Causes include diabetic ketoacidosis, renal failure, and lactic acidosis. Patients with DKA may exhibit Kussmaul respirations and fruity breath. In summary, determine whether the primary problem is respiratory or metabolic by identifying whether CO2 or bicarbonate is driving the pH change.
Now let's focus on renal compensation and carbon dioxide retention. First, the renal role in acid-base balance. Under normal conditions, the kidneys remove hydrogen ions from the body and reabsorb or generate bicarbonate. This allows the kidneys to control pH over the long term. In chronic kidney disease, the kidneys cannot remove enough acid and bicarbonate levels decrease. This leads to chronic metabolic acidosis. It is important to remember that renal compensation is slow. It occurs over hours to days, not minutes. Now let's discuss CO2 narcosis. In patients with chronic CO2 retention, such as those with COPD, Breathing may be driven by low oxygen levels rather than carbon dioxide levels. If too much oxygen is administered, the respiratory drive can decrease, causing CO2 levels to rise further. Nursing priorities include maintaining an oxygen saturation goal of 88 to 92% and closely monitoring level of consciousness. Finally, worsening CO2 retention. Early signs include shallow breathing, confusion, and drowsiness. Laboratory findings will show rising PaCO2. If not addressed, this can progress to respiratory failure. In summary, the kidneys regulate pH slowly over time, and in chronic CO2 retainers, careful oxygen management is essential to prevent respiratory compromise.
Now let's review fluid balance, focusing on shock, dehydration, and renal regulation. First, hypovolemic shock. Common causes include hemorrhage, trauma, and severe dehydration. The pathophysiology begins with decreased preload, which leads to decreased cardiac output and ultimately decreased tissue perfusion. Clinically, patients present with tachycardia, hypotension, and oliguria. Early recognition is critical to prevent organ failure. Next, dehydration risks in older adults. Older adults are at increased risk due to decreased kidney mass, reduced thirst sensation, and frequent use of diuretics. Assessment findings include dry mucous membranes, confusion, and headache. Teaching should emphasize adequate daytime hydration. Now, ADH regulation. When serum osmolality and sodium levels rise, antidiuretic hormone is released. ADH promotes water reabsorption in the kidneys, which dilutes sodium and helps restore fluid balance. Finally, creatinine in older adults. Low muscle mass may mask elevated creatinine levels. Even a small increase can indicate significant renal decline. Monitor urine output and trends closely, rather than relying on a single lab value. In summary, recognize early signs of hypovolemia, monitor dehydration risks in older adults, understand ADH's role in water balance, and assess creatinine trends carefully.
Now let's review several important electrolyte imbalances. First, hypocalcemia post-thyroidectomy. After thyroid surgery, hypocalcemia may occur due to disruption of the parathyroid glands. Signs include tingling around the lips and fingers, tetany, and positive Chvostek or Trousseau signs. If not recognized, hypocalcemia can lead to seizures and airway compromise. Next, hypermagnesemia. Hypermagnesemia is commonly caused by renal failure or excessive magnesium intake. Clinically, patients may present with bradypnea, hypotension, and decreased level of consciousness. Magnesium has a depressant effect on neuromuscular function, so the overall effect is neuromuscular depression. Finally, hypernatremia. Hypernatremia is caused by water deficit. The effect is cellular dehydration, especially affecting brain cells. Clinical signs include weakness, headache, and neurologic changes. In summary, post-thyroidectomy patients are at risk for hypocalcemia. Renal dysfunction can lead to hypermagnesemia, and water deficit causes hypernatremia with neurologic symptoms.
Now let's continue with additional electrolyte and acid-base imbalances. First, hypokalemia and metabolic alkalosis. Common causes include diuretics and metabolic alkalosis. In alkalosis, potassium shifts into cells, which lowers serum potassium levels. Clinically, patients may experience muscle weakness and dysrhythmias. Cardiac monitoring is essential when potassium is low. Next, gastrointestinal loss leading to metabolic alkalosis. Vomiting and NG suction cause loss of hydrochloric acid from the stomach. This hydrogen ion loss increases bicarbonate levels, resulting in metabolic alkalosis. Now, sodium control and thiazide diuretics. Thiazide diuretics, such as hydrochlorothiazide, lower blood pressure by increasing sodium and water excretion. However, they also increase potassium loss, placing patients at risk for hypokalemia. Nursing interventions include encouraging potassium-rich foods. Sodium restriction is also important. Limiting processed and canned foods and choosing fresh options helps reduce water retention and control blood pressure. In summary, potassium shifts contribute to hypokalemia and alkalosis. GI losses can cause metabolic alkalosis, and thiazide diuretics require careful potassium and sodium monitoring.
Now let's review IV therapy complications and safety. First, IV infiltration. Infiltration occurs when the catheter becomes dislodged and fluid leaks into surrounding tissue. Signs include swelling, coolness, and discomfort at the IV site. The immediate action is to stop the infusion and remove the IV catheter. Early recognition prevents tissue damage. Next, vesicant medications. Vesicants are medications that can cause severe tissue injury if they leak outside the vein. The major risk is tissue necrosis. Signs include burning, pain, and swelling at the site. If vesicant extravasation is suspected, stop the infusion immediately and follow facility protocol. Finally, unsafe IV orders. For example, an order of 9,000 milliliters over 6 hours equals 1,500 milliliters per hour, which is unsafe. The appropriate action is to hold the order, notify the provider, and document clearly. Always clarify unsafe or questionable orders before proceeding. In summary, stop infiltration immediately, treat vesicant leakage as an emergency, and never administer an unsafe IV order without clarification.
To wrap up, this final slide provides a brief review of common dosage calculations. I encourage you to work through each question independently to strengthen both your accuracy and your confidence in medication math.
Thank you for reviewing Unit 9, Cardiac, Oxygenation, Fluid, and Electrolyte Management. In this unit, we focused on systematic ABG interpretation, renal compensation, shock recognition, electrolyte imbalances, IV therapy safety, and accurate infusion calculations. In summary, always assess airway, breathing, and circulation first. Interpret acid-base disorders step by step. Monitor trends in renal function. Recognize early signs of electrolyte imbalance and prioritize patient safety in IV therapy. Continue practicing dosage calculations to strengthen both accuracy and clinical confidence. I'll see you in the next time.